Good morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement here at the University of Kansas Health System, sitting in for our Chief Medical Officer, Dr. Steve Stites. He's out exploring today and actually all of next week for some well-deserved R&R. We're coming to you from the Dolph Simons Jr. Family Broadcast Studio. Before we get into the rest of our conversation and question and answer session today, we have important breaking medical news to share briefly. Then we'll get to your questions, as we typically do on Fridays. But first, Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, is here with our numbers. How did we do overnight, Dana?
Yeah, we're still doing pretty good. 13 active acute infections in the hospital, 4 in the ICU, but 3 of those on the ventilator, so a large proportion on the ventilator. 17 in that recovery period, and Hayes now has a patient, and we knew that probably would not last long, that they didn't have any patients. It's an ICU patient, but not intubated. So again, I think right now we are probably at some sort of equilibrium, and we'll vacillate between, maybe 5 to 10 to 15 patients active in the hospital at one time. Hopefully that number can go lower, but that's where we're at today.
We had a lot of questions yesterday from around the metro on our Chief Medical Officer call because we had seen from day to day some increase, even a doubling. One day we were at 6 and then we were at 12.
Yeah.
That pattern has actually happened in some other hospitals across the metro too, but no huge jump to 30 or 40 or 50. And so we'll keep watching that. I think we've mentioned that before as our friends from other healthcare systems across the metro have been here to share their stories and what's happening in their places. And so we connect at least once a week, sometimes more if we need to. And yesterday there was a lot of talk about, is this the start of something more? And I know that's always in the back of everyone's mind.
Yeah, and that's why vaccination is so important, to help prevent hospitalization and those severe illness and those trips to the ICU.
For sure. Well, as promised, the big medical story of the day will not be about COVID-19, but it is remarkable news to be sharing during a pandemic. We expect today the FDA to approve a medical treatment for multiple myeloma, the third most common blood cancer. The American Cancer Society reports 1 in 132 people are at risk of getting multiple myeloma in their lifetime, with seniors being at the most risk. The new treatment is a CAR T cell therapy, and it represents a real hope. You might even call it a cure. To explain more, we've asked the Medical Director of Plasma Cancers here at the University of Kansas Cancer Center to join us. Good morning, Dr. Al-Ola Abdallah. Our audience may be more familiar with multiple myeloma since NBC News anchor Tom Brokaw was diagnosed with it. But for now, for those who may not know, what does this cancer do and how does it impact patients?
Thank you very much for interviewing me. And as you said, multiple myeloma is one of the blood cancers, kind of a rare form of a blood cancer that affect our immune system, particularly the plasma cells that usually produce antibodies that usually protect us from infections. Unfortunately, when these plasma cells become cancer, it increases the production of these antibodies, which causes complications, and that causes a lot of impact on the patients and causes life-threatening conditions. This impact could be in the form of fracture of the bone. It could be a form of acute kidney injury that patient might end up on dialysis, or it can be an anemia or high calcium level, and that requires an urgent treatment for these myeloma patients.
The pandemic has been stressful for everyone, but you and your colleagues must have been especially concerned for your patients. How has COVID impacted them in their lives?
That is really a very important question because, unfortunately, as other cancers, and especially in multiple myeloma, they're already immune compromised. And the treatment that we give also causes their immune system to be also compromised more. And COVID-19 really affected these patients by increasing they are more liable for this infection. They have a severity of this infection, and unfortunately, the mortality rate is higher in this population of myeloma patients. Also, on the other hand, we also have a lot of myeloma patients, if not most of them, they're always on treatment due to the fact that myeloma is a kind of a chronic disease that myeloma patient required to be on treatment most of the time. And when they get this infection, unfortunately, there's going to be a lot of interruption of treatment, which will cause impact on the myeloma and increase the risk of relapse of the disease.
Yeah. As a chronic disease form of cancer, as you mentioned, right, for patients who are regularly on treatment, something like this has a very different impact. So we expect an FDA approval today of a new treatment. Tell us exactly what that is, how it works, and why you're so excited about it.
Well, we're very excited because in KU Medical Center, we have a substantial CAR T-cell program, and we have a lot of novel research programs, and we were watching and observing this type of trials for our myeloma patients, especially the need of this trial. CAR T-cell, or chimeric antigen receptor, it's a new form of engineering our T-cells. Our T cells usually work in terms of like attacking attacking any type of infection and also killing cancer cells. Unfortunately, some of the cancer cells find a way to escape from these T cells. And what our scientists find is a way that they can engineer these T cells to go ahead and attack by providing type of protein recognition. And these are the CAR, the chimeric antigen receptor. And that targets the cancer cells, especially in myeloma. And after that, they reinfuse these T cells back to the patient, which will attack the cancer cells. And by attaching to the cancer cells, producing cytokines, which is toxic to the cancer cells and causing death of these cancer cells. Now, that what we see as a mechanism of action in clinical trials. These patients who are heavily treated, this CAR T cell was really working very nicely for these patients, especially if they exhausted all their options. And we're talking about a response rate that exceeds 73%. 33% of these patients went to complete remission, with a median progression-free survival about 8 to 9 months. So for us in the myeloma community, for those who actually exhaust a lot of options, this is considered really a great revolutionary treatment.
And how do people qualify for this treatment if it's approved by the FDA?
So most likely these patients have to relapse on multiple lines of therapy, but including the main 3 types of treatment that we consider as, the main treatments for myeloma: a proteasome inhibitor, an immunomodulator drug, and an anti-CD38 and an antibody. If they progress on these type of treatments, they're really qualified for this. Also, don't forget, since this is not a clinical trial, some patients were excluded, for different reasons, for mild congestive heart failure or some mild renal failure that they have. These patients will have the opportunity also to get this type of therapy.
You mentioned the sort of standard treatments, and patients would qualify for CAR T if they hadn't responded well to those therapies. I believe most of the existing therapy lines that you've mentioned are sort of long, chronic therapy, drawn out, hard on patients. Is there a difference from a patient perspective in what CAR T treatments might be compared to, say, some of those more standard therapies?
Yeah, of course, again, as we say about myeloma, it's really not a curable disease, and majority of the patients who need the treatment, in order to have an effective therapy, you have to be on, as an effective therapy, 3 different drugs, which means more toxicity and, more office visits for the patients, more visits in the infusion center. The unique thing about the CAR T cell, not only about the response rate and how long these patients can respond for that, it's also a one-time treatment. So after they infuse the treatment, there's no maintenance therapy. And I think that really, from our observation in clinical trials, really make a big difference for our myeloma patient, that they feel there is a much better quality of life after they receive the treatment.
Yeah, definitely huge. How many patients do you think we have waiting to hear this good news today?
So in my clinic alone, I have at least 45 patients that we're waiting actually to put them on this type of a treatment once it get commercially approved, because they're not eligible for our extensive clinical trials that we have here in KU Medical Center.
And if the FDA were to grant approval today, how quickly do you think it would be before we're offering this treatment to our patients?
So since we have a great substantial CAR T cell program here in KU Medical Center with all our research and all our resources, I think, once it get approved, I'm hoping at the second week of April, we'll start actually seeing these patients and start the action of treating these patients with the CAR T cell.
Excellent. Thanks so much for joining us and for the anticipated good news today. We will watch and wait with you, and definitely bring you back to talk more about this therapy as it continues through the official approval process.
Thank you very much.
Can we put where you can...
Yes, on the screen you should see a number for our nurse navigator for CAR T therapy if you think you have questions or may qualify. The nurse navigator number is there, as well as the Cancer Center website with more information. Before we jump into our community questions today, are there any reporter questions on the line?
I have a couple of reporter questions. Donna Pittman wants to know, the city of Kansas City announced it's extending its mask order through May 1st. St. Joseph and Joplin may have let their mandates expire earlier than expected. Her question is, with the cases rising, how long should we keep wearing our masks? Through the summer? Despite whatever the city and the governments are going to do, they want to know what the doctors think we should do.
Well, I would say first,
And Amanda.
just because there is or is not a mask mandate in your particular jurisdiction doesn't mean you can't do the right thing either way. And so the question of how long should we be doing this is maybe slightly different. As long as we need to, I guess, would be my answer. And Dana is going to look into his crystal ball and tell us when that is.
No, Amanda's good for that. She's the genie.
Well, I think it's important to keep in mind that the CDC still recommends that even if you're vaccinated, that you still need to be wearing a mask at this time. So until we hear differently, or until I think you said keep it on as long as we need to, I think we still need to be wearing masks regardless of a mandate.
Yeah. Because we know, and there's undoubted proof now through publications, well done peer-reviewed publications, that mask mandates, along with other issues in public health, such as the distancing and not meeting in large groups, those things help to prevent spread. And now with more news of the variants spreading as well, that's all the more important. But we know, luckily there still are some communities and businesses in Texas where they lifted their masks that still require masking as well. So it does boil down to individual behavior at that point.
All right, and then Channel 41's Jordan Betts wants to know, she's going to be doing an interview later with a long hauler, and she would like to hear from you today. How is the post-COVID clinic or the long COVID clinic going here? Is it fully open to the public? And then her second follow-up question is, what specialty are we seeing the most of in that clinic?
Yeah. We had Dr. Keith Sale on, who was one of our VPs of ambulatory, who helps run the COVID-19 long haulers clinic or post-acute clinic. We are, I believe, open now to external referrals, and again, you need your primary physician or your primary medical team to make that referral, and through that is going to be the best way to get expedited to the specialties that you need to see. What we see is probably the top 4 main long haul symptoms continue to be brain fog, fatigue, cough or shortness of breath, and then, again, that loss of smell or taste as well. So we will get you into the expedited group or subspecialty that you need to be in. Again, a lot of it's going to be, say, neurology for the brain fog, or pulmonology and the lung doctors for your cough and shortness of breath. Maybe it's a rehab medicine or physical medicine for just the fatigue and aches. And then, of course, probably ENT. We do have a physician specializing in loss of smell, so it would be the ENT subspecialty for that.
Okay. All right. So I think what we're going to do is start with a few questions that we're getting in this morning, and then we'll go to our 9 questions that we have, and we will rock right through this. The first question today comes from Debbie, and this is for Dr. Hawk. She said, our church received word from the Archdiocese that starting this Sunday, the congregation could resume regular singing. Masks and distancing will still be required. She goes, what do you think about allowing singing in church with masks and distancing?
Yeah, I think masks are going to be the most important thing. Most churches and congregations are distanced. That's a good thing as well. I believe it goes down to, your individual county and the direction you get from your county, because I think a lot of congregations are looking for their county. I think it's still a little bit risky, but of course, masking is going to help. And hopefully, those older populations, those most vulnerable populations there at church will also have been vaccinated by this point in time as well. So again, it's just a matter of risk mitigation, and just understand there probably is that risk. But from what I know, a lot of churches and congregations are very good about requiring masks. And so if you're doing it in that sense, it's certainly going to be safer than not masking at all.
All right, Sherry says Scout Summer Camp is planning to feed campers.
Yeah.
In a dining hall at 50%, but it will still be 250 unmasked, yelling, screaming people at 4-foot square tables, anywhere from 4 to 8 people at a table. She wants to know, my question is that a super spreader event?
Well, I might start by saying I'll actually be spending maybe 7 days with my oldest at Bartle this year. And the plan there, as has been explained to parents, is that that you will receive food, that the camp will be feeding those attending this year. You will receive it in a line with a mask on, and you will return to your campsite to be able to be in a small group and to have, be outside physically distanced. And so I think maybe the plans are still in motion, and I think the question is a great one. I don't know that 200 or 250 people of any sort, screaming children or otherwise, in the same indoor location at 4-foot tables, if that really is the plan, that's probably not the ideal. We've learned, I think, in schools as well, for example, how to manage feeding large groups of children in different waves and in different ways than lunchtime may have looked in previous years. And I think some of those lessons can be transferred to Scout Camp. The question of children less at risk, more at risk, definitely less at risk of severe disease from COVID than, say, someone who's 60 or 65. But probably not a whole lot less risk of transmission in the Scout age group. It's not like we're talking 3 or 4-year-olds.
No.
All right, different Debbie wants to know, we heard from a family friend that there's a new COVID case in a local nursing home. So our question is, how can that be? And then also she said it makes her wonder, I thought everybody was getting their vaccinations in the nursing home, and she wants to know, are we at 100% people getting vaccinations here in terms of our employees?
That's a good question.
Lots of questions.
So, my grandmother, who will be 98 next week, is in a nursing facility not in here, up in Illinois, and they had a case as well. But that was brought in by a worker. So for the most part, yes, the nursing home residents from that I know of and the patients are vaccinated. There has not been a 100% uptake of the vaccine in a lot of the nursing home or nursing facility employees. And so that could be what it is. Again, but we are pretty confident that even if the residents who have been vaccinated do get COVID-19, they are going to be significantly protected from having to go to the hospital, having to go to the ICU, and dying. So I think a lot of the issues about bringing COVID-19 or finding cases in the nursing facility probably revolve around the employees.
A couple of comments on that. The first one being, when I looked through our census today and over the last couple of weeks, I have not seen that significant number of patients that were coming in from nursing care facilities like we were seeing previously to the vaccine. So I think your point about it preventing hospitalization is absolutely true. In regards to our own employees, we know that we've had cases of new onset COVID even after being fully vaccinated, none of them requiring hospitalization, which is really the point of vaccination. And then I believe our most recent volumes of employees participation in the vaccine is between 80 and 90%. So it's pretty good, but not at 100% quite yet.
Yeah, specifically on the skilled nursing facility question, the population that was vaccinated by the federal program was the population that was in those facilities at the time of the program. So that program has stopped, I think is the point I'm making. And so there are constantly people leaving skilled nursing facilities, either because they improve and don't need that level of care anymore, or because they pass away. And there are also new people coming in. And so the population is definitely not 100%. So first of all, it would be very possible for someone to be in a skilled facility right now and not be vaccinated. Now, not a lot of people and not the majority, and that's really the big benefit. Secondly, we talked really here about the uptake among the healthcare workers in those sorts of facilities. And some of the early reports across Kansas were that uptake was really low, like 30 or 40%, or less than 50 to be sure. And as we dug into that a little bit, there was a lot of feeling from a number of those employees who had recently been positive that they didn't need the first round of vaccination. They shouldn't take an early vaccine. They should instead allow it to be saved for someone else because they knew they had natural immunity. And so just take that sort of statistic of less than half with a grain of salt. No doubt there are some in that population who of healthcare workers who are not vaccinated and who don't have natural immunity. But it's a little hard to get the full picture there. But even if everyone in a population is vaccinated, we know that the efficacy for preventing severe disease in these patients, in those vaccinated, in patients who are vaccinated, is not 100%. So there will be breakthrough infections. Now, the goal is that they're less severe, that they don't end up in the hospital, those sorts of things. And we do watch that among our population. As of Tuesday, I haven't heard of any new positives since then, but as of Tuesday, we had 2 total documented infections in our population of vaccinated employees who were more than 2 weeks out from their second vaccine and then testing positive. So it will happen. A single case in a nursing home shouldn't scare any of us for any of those reasons we just talked about.
I think that's a good point that you make. Those nursing facility censuses are not static. So you do have people, and you could certainly have missed being able to get vaccinated either as an outpatient because you were in the hospital, or before or after they were already giving the vaccine in the nursing facility.
And so we're well aware of that problem. Some states have chosen to continue specific programs to vaccinate anyone new on a regular basis in a skilled nursing facility. Other states have sort of said, can you figure out how to do that at the time of discharge? How to make sure that someone who's going to a skilled nursing facility who's not been vaccinated yet gets vaccinated at the time of discharge from the hospital. That's a little hard with a Pfizer or a Moderna, which require a sort of a second injection appointment for those who may not be able to travel. That's definitely a very good role for Johnson & Johnson as it sort of gets out in the community. And so we're well on our way for plans for that here, and I think most hospitals are thinking the same thing.
2 more Today questions, and then we'll get to our 9 that we had planned on. Shirley wants to know, would a 275-pound man get the same vaccine dose as a 100-pound woman?
Yes.
Yes.
Short answer is yes.
So in the trials for any of these vaccines, the appropriate dosing for body weight, size, those sorts of things was established, and the dose is really intended to be the amount of the viral particle or the mRNA or you're right, whatever the mechanism of the vaccine is, the amount of that sort of stimulant, if you will, for the immune system that is necessary to generate the immune response. And that is, while it's dependent on weight, not dependent on weight, say a difference between 100 pounds and 275.
Yeah, and remember, it's not like an antibiotic or another drug that you give based on weight, because it has to go into the body and get into all the tissues. What you're doing is you're presenting this antigen, this spike protein, to your immune system, and from there, the immune system and the cells and the B cells and the T cells are going to have clonal expansion. So they are going to expand, and it really doesn't have to do with volume distribution, how big your body is. It's just inherent what's going to be going on with your immune system and being able to expand and create that adaptive and that specific immunity to the spike protein to SARS-CoV-2.
And Joanne and Lisa have questions about multiple myeloma patients. Can they get the vaccine, and does the vaccine work in them?
Is Dr. Abdullah still on? I'd certainly give him a chance to answer that question.
Yeah, he's not here. He had to go.
But again, I think for all of these patients, especially when you have complex disease and you have medical teams, especially hematology, oncology, organ transplant teams, discuss with them. But it will be safe. Can you get it? You are probably still going to get it. A lot of these teams and these programs for different conditions will have vaccination schedules. We know that's true for bone marrow transplant, solid organ transplant. You're still going to get it, and more than likely, you are probably still getting your influenza vaccine every year as well. So I would say the short answer to that, again, is yes. The big question is, will you be able to mount that immune response? So we just don't know. That's why, depending on the nuances of your specific disease, just talk with your medical team about that.
Yeah. the biggest conversation I think with your medical team to have is in those specific circumstances relates to timing of other treatment.
Yep.
And so the answer is yes, you will still get the vaccine. The question is when is the most appropriate time from the perspective of other treatment options and generating as much immune response as you can.
And aside from severe anaphylactic response, is there really a medical condition that prevents you from having the vaccine? And I think the answer to that is no.
No, we haven't.
All right, here we go. Ready?
Yeah.
If you get COVID-19 after receiving the first dose and have mild symptoms, can you participate in the clinical trials for outpatient medications here at KUMC? I think it's Dr. Castro's trials.
Yeah, this would be in Dr. Castro's wheelhouse. What I can tell you is that for the non-trial monoclonal antibody therapy, again, we do have trials with that, but we also have the non-trial that we give to patients who are positive. You are still able to get the monoclonal antibody therapy if you are less than 15 days from that first dose. More than 15 days, you would not be meet criteria to get that. So I don't know specifically about the trials. I would expect that they do have something of that written in to allow people in. Just don't know if it would be like after a certain date from that first dose.
For sure, the coordinators, the research coordinators can answer those specific questions because the answer is going to be it depends. It depends on the time frame and your symptoms, and then of course the trial. And so whether you qualify. And so if you have any questions, please do reach out to those clinic coordinators and research coordinators. They can very much work you through the process quickly of deciding if you're eligible.
All right. Next question. I have a friend in Washington, D.C., whose work policy requires they quarantine if they are 90 days post-vaccine and are exposed to COVID-19. Why is that necessary, or is it?
So a couple of comments on this. I would say we know that local health departments and county health departments and state health department guidelines vary. So I haven't specifically brushed up on the Washington, D.C. guidelines. It's hard enough to keep up with Kansas and Missouri. But that very likely could be something that they have in place as in regards to whether or not it's necessary. I know that the CDC guidelines don't specifically indicate that that would be warranted. You would still need to monitor for symptoms during that 14-day period post-exposure. But again, that's really going to be at the jurisdiction of the local health department.
And I think, right, that's a very conservative stance.
Yep.
Doesn't hurt anything. The reason for it, I think we all could explain, is that we still don't know. We don't have a lot of evidence for people who are exposed who are 110 or 140 or 200 days out of vaccine because we really only started vaccinating the population at large in January. And so we'll know more in time. But that's just a very safe and conservative approach. And so while it may not be necessary and there may be some variation in what individual jurisdictions are asking, it definitely doesn't hurt anything.
And this next question is from Isaac. He asked it last week and I missed it. So this is for you, Isaac. I had neck pain after receiving my vaccine. Is it possible the vaccine caused the neck pain also? I took ibuprofen for the pain. Will my vaccine still be effective?
Well, first, I mean, Jill's doing everything to try to make it right, Isaac, so
Yeah.
here we go. Dana, you get questions about symptoms related to vaccination, and did it cause this a lot? I think it's probably safe to start there.
Yeah. I mean, it's hard to understand, really. Certainly, I would imagine if you had the symptoms starting 8 to 12 to 24 hours later. We know that headache and kind of radiating down to your neck can occur with different illnesses, but also with this vaccine that can cause that. So it's certainly possible. But it probably went away. You did take medicine, so I don't think it was anything too significant. And no, the ibuprofen that you took should not affect the time moving forward in the next 3, 4, 5 days, 2 weeks to create that immune response. So that will not be a significant issue.
Is there a live virus in the J&J vaccine? How does it differ from the other vaccines being offered?
I think first, it's great to recognize that there are different sort of categories or flavors of COVID-19 vaccine, and the J&J is not just different in its sort of logistical and handling characteristics or the fact that it's a single dose. So the mechanism is different, but it's pretty easy to answer the question, is there a live virus in it?
Yes. The short answer is no, it's not a live virus. Once it gets injected into you, it does not replicate and make more viruses. All it does is give your body the ability to show that spike protein to your immune cells so that you can generate immune response against that spike protein.
All right. It has been reported that people who have had COVID-19 may not need 2 doses of the vaccine. Is that true?
Well, it's definitely true that it's been reported.
Yeah.
And it's also true that there's probably a scientific mechanism that makes sense for that, and people are studying it.
Yeah.
But to this point, there's no formal recommendation that we should treat anyone who's had a recent infection any differently in the sense of vaccination timing or dosing.
Yeah,
so
no.
if you were supposed to get 2 doses of your vaccine, then you need to get your second dose. If you're part of the Johnson & Johnson, then the 1 dose would be all you would need.
Yeah, and again, that goes to the durability. We know that second dose is really going to improve the durability, meaning how long that immune response lasts. In fact, there was a good article published this week in New England Journal of Medicine by our colleagues over at Children's Mercy that actually looked at people who had had the infection and then received their first dose versus people who didn't have the infection and received their first dose. And what they did show is that certainly the antibody levels were higher in those people who had previously been infected. But it's good initial information, but we understand that the data and the trials to get the EUA for Moderna and Pfizer really relied on that 2 doses. So still get your second dose, but there's information signaling that maybe there are higher antibody levels after that first dose if you've had COVID-19 in the past versus if you didn't. But again, we don't know what correlate of immunity that leads to. And again, there are other things. It's not just antibody levels, it's T cells as well. So there's a lot of things going on, but just as you said, yes, it's been reported, but we still need to get that second dose if you got Moderna and Pfizer.
All right. A former FDA commissioner was quoted in the news as saying, between those who have had COVID-19 and those who have been vaccinated, the U.S. could be at 50% herd immunity. Do you agree, and is that enough to stop wearing masks and go back to life as before?
Well, may start maybe with could we be at 50% of the population between those vaccinated and those who've had the disease that have some degree of immunity? And I think that that is actually a possible number. It's not out of the realm of possibility. So wouldn't disagree that that could be the case. As far as whether that means we have enough herd immunity, that's an easy answer, and that's no. The minimum sort of estimate would be about 65 to 70% of the population needing active, durable immunity to start to see a population benefit, meaning that the immunity in a population prevents outbreaks and spread. And it's actually more likely that for this disease, for this respiratory illness and the way that it is transmitted and the ease with which it spreads, that the number is actually higher, maybe even as high as 80 or 85% of the population. And we know we're not there. So definitely not at the point where we can consider population-based immunity as a strategy to stop other mitigation measures. Lots of other things, I'm sure, that you both will add to that.
Yeah,
but
I wouldn't want to respond to not wearing masks based off of we could be at 50%. I'd rather go off of we know the population that's been vaccinated and make our judgments based off of an actual number versus a could be.
Yeah, and I think another important point is research has also shown that people who are vaccinated compared to people who had asymptomatic disease, meaning no symptoms at all, or mild disease with very low level of symptoms and not having to go to the hospital, have a lower level of immunity, or at least antibody levels, compared to those that have been vaccinated as well. So vaccination is going to be very important. And again, like I said before in the last answer, we don't know what antibody level gives you protection. And of course, there's other T cell responses as well. But we have seen that vaccination does probably increase your immunity compared to low level of natural infection.
All right, 3 more questions. I had strong side effects from the first shot of the vaccine, but then I had COVID-19 this winter. Will I likely have an even stronger reaction to my second shot?
I don't know if they've actually been able to publish anything that would suggest this. I know there's so much variability in folks who've had COVID, folks who've not had COVID, and their response to vaccine 1 and vaccine number 2. It's extremely variable, so I don't think there's we can't say one way or another on that one.
when we've seen from sort of our experience, some people who've had a very significant sort of side effect response, meaning when I say very significant, I mean lots of aches, chills, fevers, just not feeling well, the things that we would expect from their first dose, and they've been really nervous about their second. They get their second and they don't have nearly the same response. And then we've had the opposite. We've had people who've had really very small side effects from their profiles from their first dose, and then their second dose really sort of sets them down at home and on the couch for a day or so, and was much greater in the sense of symptoms than their first. And not really sure what that's from, but it's been all over the map.
All right, what is the average age of people being hospitalized now? Where and how are they catching COVID-19?
So I looked at this over the course of the last few days. I've been paying attention to this. So we have quite a bit of variability right now in our age range, everywhere from 19 all the way up to age 92. It's hard to see at a quick glance where they're coming from or how they're contracting it. Again, I mentioned this earlier, but we're not seeing it from nursing home facilities, which is different than what we were seeing early on. Some of our patients are coming in asymptomatic, and we're just doing it as a part of their admission screen, and then we find out that they're COVID positive. So it's we have a wide variety. Even within our ICU right now, we have age 30 up, or well, actually 19. An age 30, and then in the 50s and up to 92.
Yeah, when we look at the data over a little bit bigger time period, so if we look at the month, say, of February and then month to date in March compared to November and December, what is very true is that the percentage of our overall admissions that are 75 and over is significantly decreased. So we're clearly seeing a benefit from the impact of vaccination in the 65 and over crowd. Interestingly enough, our 65 to 75-year-old age range is exactly the same as far as the percentage of the admissions. Of course, it's of a smaller number of admissions, but the percentage is the same. And there were lots of questions from across the state, including some of our legislators, who asked, isn't it like 20 and 30-year-olds who are now in your hospital? And really, there's been no significant change. It's like 7% of our admissions were 20 to 30 years old in November and December, and 7.5% in the last 6 or 7 weeks. So it really appears that the decrease is in those who've been vaccinated, and the rest is this variability that, Amanda, you've talked about, without a really significant change in the age bands or the percentages of the overall admissions.
And our last question for today. My daughter is a month out from her second vaccine. Last week, she went to urgent care with strep throat symptoms, but the test was negative. Should they have tested her for COVID-19? They didn't offer since she was so far out from her vaccine.
I think she probably, if she had COVID-like symptoms, probably could have been tested for
would have
that
been
and the other
reasonable.
respiratory viruses.
Yeah, I definitely think it's reasonable to have tested.
In that situation, what does the patient do? Do they ask?
Always, I think
Do they
it's fair to
advocate
ask
for
the
themselves?
question.
Yeah.
And if you feel like the answer that you get there, say you're at an urgent care, it doesn't really give you everything you need. It's always, of course, the right answer to reach out to your primary care provider and ask those questions. Doesn't mean you're demanding anything. It simply says, I'm worried about this. Am I worried about the right things? And that's always right. The engagement of our patients in their care to that effect is something that we always want and encourage. So I would say ask if you have any question or concern.
Yeah, because right now, even if you've had the vaccine, if you get COVID-19, the guidance is still to isolate for those 10 days. So that's not going to change that. And it's going to be important to stay isolated. So although you probably have reduced chance of spreading it to others, we just want to make that chance, close to zero as possible. So being that isolated for that 10 days after your symptoms start is going to be the important thing.
Yeah, and I think if you are symptomatic, and it sounds like if she was being tested for strep, she probably had some symptoms. Testing is reasonable, and we still have plenty of testing sites available for that.
All right. Before we talk about next week, I'll throw one out there because I've gotten 2 or 3 texts while we've been here on the update this morning. I know yesterday there was a question about anaphylaxis and a circumstance in Kansas. And the questions this morning have been, to me at least, do you know any more about this? And is anaphylaxis really a problem? And, should we be worried? And so I'll maybe start with... Of course, we know anaphylaxis with any vaccine is a possibility. And anaphylaxis is an emergency condition and can, of course, cause severe consequences, including even death. We don't know anything about the circumstances of this case, really, and so Number one, it's a little bit too early for us to say, was anaphylaxis the cause here? Was it anaphylaxis related to the vaccine? We just don't know. We don't have any information. So we can't answer that, do we know anymore? But I still think it's important for all of us to talk about the fact that there are heart attacks and strokes and anaphylactic reactions and car accidents and new cancer diagnoses and neck pain and all of these things that we've talked about. Those things just happen in the population. And they're going to continue to happen in the population that receives vaccines and in the population who hasn't. And so those things shouldn't be reasons to be scared or shouldn't mean at all that you should avoid getting your vaccine. I think as we've shared here repeatedly, there are data safety monitoring boards looking at all of the data that comes out of vaccinations and side effects and adverse effects, and we'll continue to study and share that information. But we know with absolute certainty that even those things that will be happening are so much more unlikely than severe consequences of a COVID infection. And so I think for all of us, and I'll invite Dana and Amanda to weigh in here, but for all of us, these questions are things that we will and should have answers to here over time as it relates to this specific circumstance or any others. But even as we get those answers, there won't be answers that say you shouldn't get your vaccine.
Mm-hmm. Yeah, I don't have anything to add to that. It absolutely get your vaccine.
Yeah, and I would just like to thank Dr. Abdullah today and the CAR T therapy announcement. And again, that's a T cells. Thank your T cells, because T cells are important for this. They're important for resolution and getting over viral illnesses like COVID-19. They play a very important part. The other thing is be thankful about our ability to get the vaccines and have the vaccines in a year since COVID was first identified and caused the pandemic. There was a new publication out of New England Journal of Medicine just earlier this week that showed that an HIV vaccine did not actually protect and had no efficacy in protecting people from HIV. And we've been trying to get a vaccine for HIV for almost 40 years now. So the fact that we've developed this very safe and very efficacious COVID-19 vaccines, of which 3 are approved right now in the United States, or emergency use authorized. Be thankful for that, because there is a way forward. We're lucky it's not like HIV, in which we've been trying to identify a vaccine for the past 40 years and still have been unable to do it. So.
I think Dana just jumped right to final thoughts.
Yeah.
So from you, Amanda?
I think some of the questions today really spoke to, can we take our masks off? Is it time to return to normal? And I think the takeaway right now is hang in there just a little bit longer. We're not quite there yet. Keep wearing your masks. Keep maintaining your distance. Avoid those large gatherings.
And I'll weigh in just a little bit with one other final thought before we talk about next week. I do actually expect that over the next week or two, we will see more doses, more vaccine inventory hitting every vaccination site in the metro. Some of the conversations with our health departments and their leaders over the past day or two really signal that the ramp up that we anticipated will be starting, in inventory will be starting here pretty quickly. So if you're still out there trying to get your vaccine and you're in phase 3 or 4 in Kansas or in phase in Missouri, and as we approach April 9th in Missouri, that date where really it's open for everyone, continue to reach out to those places that you have connections for healthcare, but also to your county health departments, as it does appear that we'll actually have the ability to more rapidly get to everyone who's really interested in the next couple of weeks. So good news there. Next week, on Monday, we'll answer the question, does COVID-19 cause diabetes? There have been reports that people treated for COVID-19 end up being diagnosed with diabetes, and David Robbins, the director of our KU Diabetes Institute, will join us to sort it all out. We'll talk with one of his diabetes patients who caught COVID-19. They both have a lot to share. As we say goodbye today, I really want folks to pay attention to one set of numbers that we've shared in this pandemic, and that's the daily infection rate, the 7-day average. While we have many reasons to be hopeful, we have many more reasons to remain vigilant with our pillars of infection, prevention, and control. In case you missed it yesterday and really throughout the week, here's a look at community spread last spring break compared to this year. Stay safe out there, and we'll see you Monday. watching the videos and pictures of spring break gatherings across the U.S., in Florida and other areas, where the questions have been concerning about transmission, and in some cases, like Miami Beach, where the mayor declared a state of emergency over fears that these gatherings would become super spreader parties. We thought we'd take a peek at how last year looks compared to this year as far as disease transmission in the community. This is a simple look at what's happening in Kansas. The box down at the very bottom on the left-hand side says on March 24th, 2020, 1 year ago, how many new cases per day were we seeing in the state? And that number was 45. We are already significantly higher in the number of new cases per day here in Kansas than we were a year ago, although it's been spread out over several weeks in many school districts or by many universities. The next slide is a reminder of what that translated to here in our hospital. So this is our census in the hospital, and look at where we were, right? The gray line is the total number of people in the hospital. The blue line is the ICU, and the red is the non-ICU, so people in regular hospital beds. You can see coming into the week of spring break last year, right, we were averaging in the single digits, similar to where we are now. And immediately following that, we saw an increase of several fold, actually. We went from averaging around 5 to averaging around 35 pretty quickly in a matter of a week or two. And while we don't anticipate maybe a seven-fold increase in hospital patients over the next week or two, we're definitely concerned that any event that leads to increased transmission, whether it be because of travel and gathering for spring break or anything that happens here or really anywhere related to a change in the way we are gathering and interacting, especially for those that are unvaccinated in our communities.